Oh, yeah, this is great. We're back just after Thanksgiving, and I've got two amazing guests. I think they're both still full of turkey and tryptophan, but we got to wake you guys up because we got major discussions to have. So it's been a couple of weeks. We got displaced by a Lobos game, and of course, some of the holiday festivities. But today is a real treat. We are going to be talking to two of my favorite people who are up and coming. Up till now, we've always spoken with accomplished people that have all their degrees and everything in line and been in practice for a long time. Um, Today, I want to talk about the future, and there's two bright minds that are going to help us think about medicine, uh, especially hopefully here in New Mexico in the coming decades, even. So, first is Emma Rogers, and she is a um, neurotechnician, going to be eventually a PhD in neurosciences. Did I get that right?
Yes, so I'm an interoperative
Right.
neurophysiologist, and what that means is I specialize in the communication that travels from the brain to the rest of the body during spine
Yeah.
and brain surgeries.
And we rely on her a lot in surgery. Basically, she makes sure that as we get close to some of the nerves, she sets alarms off and says, we have to be careful in that area. And so that's how precise surgery is these days. But she knows all about the nervous system. And frankly, I think we're going to talk about you going back to school and getting your sort of terminal degree, which is a PhD, a doctorate. And I can't wait to hear all about what the heck that means. Um, and then our second guest is also an up and coming guy. He is a native of Pakistan and in a beautiful area called Lahore, which is a funny name, but it is near the mountain regions. Is that right, Dr. Shazab?
Yes, sir.
And so he has come here to study with me and with some of my colleagues, and he is an up and coming neurosurgeon studying in Pakistan, and really has had an amazing opportunity to come here and kind of learn about the modern American techniques, and which include all kinds of stuff like navigation in the brain and specialized surgeries through little scopes and stuff like that. And we're going to talk about his career, which is that he would love to come and get some more significant, again, terminal level training, meaning a neurosciences and neurosurgery residency, and eventually become a doctor here. And so all of this is super exciting. I look at it and say, what kind of minds are going to be the next generation? I'm becoming an old dog. So I'm pretty excited to find out what your aspirations and dreams are all about. So I guess we'll start with Emma. So you thought about med school. You had as crazy a background as I did, right? But you kind of decided to study the nervous system and the electrophysiology of it, which means knowing where all the nerves are in the body. Was that a lot of work?
Oh, it was an unbelievable amount of work, and it's still an unbelievable amount of work. The education never ends.
So is the nervous system just the coolest part of the body, or what?
It is, but my favorite part is, of course, the overall brain, but how all of these different parts connect together that allow us to exist and move and perceive and have cognition. It's just all really incredible, in my opinion.
So I think one of the things they made us, in my training, we had to memorize this huge Kandel and Schwartz book. And for those people who don't know, that's probably, I don't know, a couple thousand pages of a textbook about the nervous system.
Light read.
Yeah, right. And I think the thing that blew my mind, I know you study this and you deal with it every day, is when you think about like picking up a glass of water, for example, the nervous system initiates that on the very surface of the brain, and then there's an electrical signal that goes all the way down to your hand. Can you kind of go through some of the planning, or do you know those pathways? Because when I think about it, like, you have these opposing digits, right? You got your thumb and your forefinger, and it's modified depending on how much force you use and whether you're going to lift it with certain parts of your nervous system and your muscle system. I mean, and it all happens how fast?
Oh, faster than turning on a light switch.
That's amazing.
Yeah, and I mean, how much time do you have? Not years to really go into all of the detail.
Well, I take me through it. So I know you study this kind of stuff when the patient's asleep. So on the surface of the brain, what's that called?
So you have the cortex, and when we in our spinal cord, which connects our brain to the rest of our body, you have at a very basic level two different pathways. One that is ascending, going up towards the brain, and the descending, which is going away from the brain.
Right.
So with sensation, which is when you think of looking at a tree or feeling a feather on your skin, that is external stimuli that we touch on our hand, and then that little bit of information goes up your arm, up your spinal cord, and into your brain. And then for motor actions, such as picking up the actual cup, it starts in your brain and then travels down through the spinal cord and goes to whatever various muscle you are activating. And these are really tiny, tiny electrical impulses that are happening across neurons and circuits. And it's happening faster than milliseconds sometimes. And if it's happening at a millisecond, there's a delay. And that's actually kind of an issue with us.
Right. I remember when I was in med school and we were studying some of the stuff, and they had just come out with like neural networks. They were trying to do computerized models, or software models of how the neurons interact with each other. I mean, there's so many cool stories about all this, but do you think that we're going to be able to get robots to replicate the brain infrastructure, the spinal cord infrastructure, be able to work as quickly as humans, with the same dexterity? And like, for example, you think I could be replaced? A robot with a brain could go and do surgery?
I think it's hubris to consider that we are not replaceable in any aspect of life. But I mean, we already have the Da Vinci robot with laparoscopic surgeries, but there's still human intervention. And I think at least where we are now and for the next probably decade at least, you are not directly replaceable because there's so many other things that go on, nuances that a robot can't replicate, at least at this time. But I'm not a robotics engineer.
No, I know, but you're so what's going to happen next? You've studied all of this stuff and you kind of decided you didn't really like to look at my horrible life as a doctor and you were like, I'm going to go get a PhD in neurosciences. So what is there left to study? You already know all this stuff, or is it all changing and new, or what are you looking forward to?
Well, everything. We have all entered this field where the education doesn't stop when you get the degree. Right. There's always more advancements, more to learn. There's always someone who knows more differences about the subject. And it's not that I don't like this. I deeply value my role in these neurosurgeries and spine surgeries. But I have a limitation in my scope of practice.
Right.
So my scope of care ends the moment the patient leaves the OR, and there's not a huge amount of continuity of care.
Right.
And I'm looking for a little bit more of that and a little bit more autonomy and a little bit more ability to just have a greater impact on patient quality of life.
Would you have your own lab?
That would be awesome if I could.
That'd be
you want to fund it?
Well, yeah. I mean, you're unbelievably bright person. I would love to see, if you could study one, there's all these diseases of the nervous system. There's tumors that grow in the nervous system. One of the ones that kind of blows my mind is something called Charcot-Marie-Tooth.
Oh my gosh, yeah.
Do you know what that is?
Yeah, I haven't really read about it a lot since completing my training because we don't see it very often.
Yeah, it's very rare, but I've had a few patients with it, and basically it's an abnormal, almost like scar that develops along the course of in these nodules along the course of the nerves, and it slows the transmissions down, and the patient starts to have significant problems. They can be almost Parkinson's like, and it's pretty tough. And I just happened to have seen a patient recently, and I'm like, man, if somebody could take that patient into a lab and study why those scars occur along and disrupt the nerves, this patient could walk again. And it's not a neurosurgical problem. We can't cut them out. Mm-hmm. It's got to be genetic engineering or something like that. All right. So when we come back, we're going to talk to Dr. Shahzeb, who's all the way here from Pakistan and has just one of the most remarkable stories. He is a fighter and a guy who cares deeply about his future and his patients. And we want to see him succeed as the future of neurosurgery. A young, bright guy. So we're going to talk to him too. All right. We'll be back in just a second. We're going to take a quick break. KKOB, the doctor is in. Okay, I'll do like that. All right, we are back with the doctors in. I have two amazing guests. They are the future of medicine, especially neurosciences, which is close to my heart, of course. So we've been speaking with Emma Rogers, who is a neurophysiologist, going to be a PhD in neurosciences. She's just working up on her applications, and so one of the brightest people I know. We're going to switch gears to another up and coming person. Dr. Shahzeb Zaib. I don't know. I screwed it up. He's an amazing guy. I want to tell you his story because he is here visiting from Pakistan and has taught me so much about how lucky we are, even though our healthcare system here is problematic and maybe not as satisfying as it should be, or people out there in the world, they live with very different circumstances and don't have anywhere near our resources. And so I'm going to share with you a little bit of his story, and then we'll ask him some questions. But he asked for my help in kind of writing his application for a residency program here in the United States for neurosurgery. And Dr. Shahzeb, everything I'm going to tell them now is true about how hard it was for you to even get a chance to come here, but get into medical school, right?
Yes, sir. It was really difficult.
Yeah. So in summary, you were a kid that grew up in Pakistan, didn't have a lot of resources. The family was pretty poor. So not a lot of people in that circumstance even get a chance to apply for medical school, right?
Yes, sir. There are in my year almost 60,000 people applied for it.
Wow.
And I was lucky enough to get into top 900.
Okay. So I think the reason that you're such a remarkable story is that he studied really hard, despite not even having sometimes electricity, right?
Yes, sir. There's a lot of load shedding, and we were just living in almost a one room house, like 10 people, 10 my siblings and 2 my parents. And my father was also not in a very good shape. He was ill, so I was the eldest, and I had to do a lot of things like daily wage work and stuff like that, and then go to school, high school as well.
Worked at a kind of a dangerous factory and all that kind of stuff.
So that's because we were living close side the factory area, and my house where I was located, there was a lot of load shedding. Like electricity would cut off.
So the electricity would just cut out.
So I had to study because in the day I was working, and in the night I had to study. So I would go out and go find out some factory, and they just put the light on because they use generators and stuff like that. So they put the light on and keep it on. So I would just sit there and keep on studying.
Okay, so this part of the story blew my mind. So you got to where you are because you were willing to go out, and there was no electricity in your house, but you took your textbooks and sometimes your sick father. And you would go either to a hospital waiting room where he could just sit and you had enough light to read. And sometimes even you yourself would go out underneath a street lamp and study all night just so you could try to pass these exams. And you eventually became a doctor. And like, we don't have that trouble here. I don't think Emma, did you study under a street light?
No, I was very fortunate to not have that hurdle, but it just shows the level of dedication that he has had.
Yeah,
I basically had no other choice, because either I would be nobody,
right,
or I would be sitting in front of you and talking to you. So I chose this path. So I thought, okay, I should do something about it, because whatever I have been given, I should make it all work. Yeah. And make it, because I feel like I'm only given one life, so I cannot blame it on other people. Like it's upon them that they're not giving me electricity.
Right.
It's upon them that they're not. No, it's upon me. Wherever I want to go, I had to.
That's incredible.
Yeah. So I think the question I want to ask you is, of course, why neurosurgery? And I think I'm going to lead you down the path of some stories that you told me. But as soon as you got a chance to become a doctor and get into the hospital, and you're in your training at this point to be a neurosurgeon, there are problems in Pakistan, like the motorbike issue we talked about, or even other diseases like Parkinson's, that you don't even have the resources to help some of these people. Tell me about the motorbike situation.
So there is a lawlessness in my country.
Lawlessness, right?
So that's the main factor. So it comes with a lot of people and even adolescents with no licenses and without helmets. You will just take your car out, and you will see hundreds and hundreds of people running
So
on bikes.
nobody owns a car; they own a little motorcycle, right?
So most of the, like 80% of the population, they own motorbikes, and they are just keep on going, and they had a lot of accidents. So daily
Is there street lights? Is the stoplights? Red, yellow, green, or
there are lights, but there are no lines. Just like in America, there are no lines, so nobody's following the line. So you always expect other people to, like, they bang in you, like in your car.
big accidents?
The big accidents, and they just, most of the time, they come with the cervical spine injuries, and also the traumatic brain injury, closed head injury. A lot of them, they come with the diffuse axonal grade 3 injury.
Right,
Like,
so that's brain trauma. So, and unfortunately, we see a lot of that here in New Mexico too, motorcycle accidents. But there's so many of them because there's no real good traffic laws, right? Do the police ever pull you over for speeding?
okay, they can pull you over, and they will take a little bit of money, and then let you
I
leave.
see. Yeah, it's not that easy here. So the biggest thing you told me was you went into the ward the first day, and there were 7 or 8 people that had broken necks, essentially, and no equipment, no ways to save them, right? They just
Yes, sir. So they just miserably died, and it just broke my heart. So I went to neurosurgery because I loved neurosurgery and all the circuits that you were asking, Emma. So I just studied, because when I went to medical school, so my curious brain, it just started looking for some very physical like kind of a subject. So I looked at the neurosurgery, neuroanatomy, and neurophysiology. So I memorized all the neurotransmitters and the circuits, and the how just like the example you gave, that if you pick up a cup of water,
right.
So there is a lot of things going on from the cortex to the basal ganglia, and even our nature is like so beautiful, that the cortex gives the command to the muscles, and at the same time it gives the command, the copy of command, to the cerebellum, so that it's always in fractional seconds, it keeps on checking all the things that we are doing according to the command. If we don't follow the command, it all of a sudden takes up the handbrake.
So what it's been a little while since I studied that level of physiology, so you guys are probably more up on it. It's brilliant stuff. What you're saying is that there are gas and brakes inside the nervous system. And so, for example, if I want to pick up this cup, I don't use all of my force, which would crush the cup. There's modifying.
Yes, sir. So there's a very beautiful thing about it, that our brain, people would think that our brain works on creating electricity, creating current, and creating a command. No, it works on inhibiting the unnecessary commands. So our brain generates millions and millions of like action potentials, and the most of the neurons, because the cortex is six layer cortex, the 5th layer and 4th layer, they are just for inhibition. So they inhibited the unwanted current, and the fine command that we want to do, that just comes up and is given to the basal ganglia, and then to the spinal cord and everywhere.
This is the stuff that got me into it in the first place. Emma, you're shaking your head like you just like the machinery that makes us just do the simplest things. How many people go about their day and have any understanding of what it takes to pick up a cup? I mean, that is some engineering, right?
Yeah, it's the vast majority of people don't think about it, and that's important. If we had to actionably think every single time I want to use 2% of my energy to pet my cat, we would not be able to function. And the last thing you want to do is go to pet your cat and use 110%.
Throw the cat over.
Yeah, that's not. It's a kind of a morbid example, but yeah, we have so many things, checks and balances within our central nervous system that allow us to do things, even such as breathing, which are autonomic things that we don't.
I was gonna go over that. So, do you want to tell the audience what Ondine's curse is, for example? Do you remember what that is? Dr. Shizab? So in other words, there's an area in the medulla that controls the frequency of your breathing and the intention to breathe. And so it's called Ondine's curse. I don't know, you probably know it as something different, but there are people who have an injury to that part of their brainstem, and they have to remember to breathe. They have to think actively about breathing. And it's a curse, of course, because most people go about their day, they don't think about the fact of having to breathe. And so you can't sleep, you can't function. It's a curse, it's deadly actually, because that is an automatic behavior that you no longer benefit from. So
it reminds me of some of the approaches to polio, when people couldn't have the functionality to actually breathe, and they had
iron lung,
but also they had specialty rocking chairs that allowed this different pressure.
Oh, really?
But they still didn't have to think about it, but they weren't able to.
I want one of those. Sit on my front porch and have it rock for me or something. Oh man, great. So we're going to come back and hear more of Dr. Shazub's story. He's one of two of our amazing guests today. Emma, also up and coming people in the neurosciences that we need to embrace and help. So the doctor's in. We'll take your questions, 505-243-3333 if you want to give us a call, and we'll be back. Okay, we are back with the doctors in, Dr. Greg Scher, and we are taking your calls if you want, 505-243-3333. I'm here with two amazing guests. They are both colleagues of mine, and they're up and coming. They're in the point of kind of working towards their doctorate degrees and becoming something important in the field, especially neurosciences. That's the one I care about. So we'll go back to Emma Rogers, and you have an amazing job. You're one of the few people in the world that gets to tell doctors and surgeons what to do. So that's kind of a remarkable thing. So you sit in the corner, you have this very fancy laptop, and you are little needles in the scalp and needles in the feet and fingers and stuff, and apply electrical signal down the nervous system, which is just a big wire, right? Or circuit. And then you get to tell us if we're getting too close or the nervous system is being manipulated or it's angry or anything like that. So I guess my first question is, do you feel super powerful? Like the wizard in the corner?
Yes and no. I I think it's really complicated. People kind of forget I'm there. And there's a saying with within anesthesiology, 95% of the time, everything's
Everything's
fine.
calm, yeah.
You're coasting. You don't necessarily have to really think about things. But then 5% of the time, it's really incredibly stressful.
Yeah.
And I do not feel all powerful when things are in that 5% of the time.
So to be clear, what happens is I'll be operating and she'll say, oh my gosh, there's some signal dropout, or there's some concern that nerve is either irritated or it may be injured, and you need to stop and we need to take a look at it and figure out what's going on. I have some amazing stories about the work that you do, but I thought I'd ask you first. Do you have one? Did you save a patient or their limb or anything by alerting people and understanding that there was an unforeseen problem happening?
Yes, I have one in particular. And while I'm not necessarily in there saving people's lives, I am preserving quality of life.
Right.
The last thing you want to do when you go in for a lower back surgery is wake up with numbness and an inability to use your arm
Legs
because
or
of
something,
how you're laying down. And I'm not going to name names.
Nope,
Obviously, I have
can't
to
do
be
that.
very careful with how I word
But
this.
just the story, yeah.
But it was a very long case, many levels in the lumbar spine. And
So screws going in and
Mhm.
manipulating the nerves around the screws.
it was sort of a light scoliosis correction, just
Mhm.
to paint the picture. And so not super aggressive changes to how the vertebral bodies are lined up, but
Mhm.
we had several interbody cages, which means those go in between
Disc
your actual,
replacements, yeah.
they go between the vertebral bodies, and then you put screws in, and the screws are there to place rods, which sort of holds everything in place until fusion occurs. And there's a lot of steps when these things happen that can go wrong. The cage can be in too deep, the screw could be placed wrong, or in the case of this case, the rods are at too aggressive of
Correction.
angle.
Yeah.
And so
Just to be clear, what we're trying to do is a person has a twisted spine, and we're trying to untwist it and straighten them in all three dimensions, really.
Mhm.
So left to right and front to back. And so if they're not used to having those bones and nerves straightened back up. And
Yeah.
so that was what was going on. And then what happened?
Yeah. So they had 3 interbody cages in, and they placed the rods, and I started noticing changes in the sensory pathway for the lower extremities. And this takes a while to occur. It takes about 2 minutes to collect this specific data. And I'm looking at really tiny electrical impulses, which sort of looks like an upside down U and a regular U together.
So these are sort of look like heartbeats or signals.
Yeah, it's a great way to
electrical
describe
signals
it.
across. Okay.
And what we're looking for is a change there. Either those curves move further away in time, it takes longer for them to reach the brain, or they go away completely. And both are problems.
It's like a lag time. You see
Mhm.
electrical signals slowing, essentially.
Yeah. And
Diminishing.
what I saw was they very quickly went away. And what you're more likely to see with sensories is they gradually go away. And there's a ton of reasons why that could happen, but obviously here it was surgical. So I started noticing this and these changes in the sensories. So I went and ran a motor where I basically just stimulate a motor contraction in all of these muscles through electric signals.
It's so cool. You control their nervous system while
Mhm.
they're asleep.
Yeah, so I ran a motor sequence, and I had lost all of the motor legs.
So potentially the patient was about to become paralyzed.
But yes, and the chance was high because the sensories
Had
and
also
the motors
diminished,
were
yeah.
gone. And
So do you start screaming?
that's when I stand up, get very loud. My presence is very well known.
red in the
OR.
face.
And I tell everyone and then I go and make
Lost
sure
your signal,
I have
yeah.
lost my signals. Whatever you just did, you need to undo, because the
Right.
patient is at risk to become permanently paralyzed
Yeah.
in both legs. And what, unbeknownst to me, they had just placed the rods. And what happened with the rods is it was too aggressive of a curve, and it had pushed one of these interbody cages
Oh, wow.
into the cauda equina, which is basically the part just below the actual spinal
Right.
cord.
Right.
And it caused subluxation and all these other things. And they weren't too sure if it was too displaced on the x-rays. They were having this conversation immediately before I stood up and told them. And so because we caught it so quickly, they were able to take out the rods, manufacture something to move the cage forward, find a different shape rod, and the sensories are the longest to go away and the longest to come back.
That's-
Motor responses are the
So
quickest to
you're
go away and
sitting
quickest
there
to come back.
chewing when you-
It's great. People don't know I'm there until they need to know I'm there. But because we were able to catch this so quickly and make the corrections, the motor started coming back. And 2 hours later, when we finished closing, the sensories finally came back within threshold baseline, and it's really beautiful. So I didn't necessarily save a life in the traditional sense,
Sure you
but
did.
but this person's still going to be able to walk,
Yeah.
and they would maybe wake up and they might have some weakness and numbness, but within 2 days, everything was back to pre-surgical baseline, which was pretty beautiful.
Oh, what a great story. So, and that didn't, I was not the surgeon, so I don't know
No.
anything,
No.
anything more about it, but certainly been through many, many things like that. And so what a cool job you have. So back to Dr. Shahzeb. Do you have neuroelectrophysiologists in the OR with you in
No, sir.
Pakistan?
No, sir, nothing like that.
So she's pretty sophisticated, wouldn't you say?
Yeah,
I think we should.
she's a blessing.
She needs a free trip to Pakistan. What if you went there and
Yay!
taught them how to, operate?
I think that'd be pretty cool. I've never been to Pakistan, but I know that the mountain ranges there are very
so I
beautiful.
invite you right now.
All right, let's go.
Yeah,
I'm not sure I am, of all the 3,000-ish neurophysiologists in the United States, I don't know if I'm the best to lead the education,
No,
but I
I
would
think
love
it's
to.
clearly after that
We can
story.
go as a team.
Yes,
All of
yes,
us.
perfect.
So another thing that you told me, as we were writing your statement for your application was not only about the motorbikes and the number of broken necks that they just unfortunately die because they don't have enough ventilators and enough ICU beds and things like that. It's just amazing that it's, here that would be unacceptable and that people would do something about it. But also, you mentioned to me that Parkinson's, which
Not only Parkinson's, sir. There are a lot of diseases like the way you guys pick up glioma, and you have a lot of screening.
brain tumors and other
You
types
have a lot of
tumors.
screening MRIs and screening CT scan. We don't have anything like that.
And how about like cancer care? If a person has cancer, can they get
so
treatments?
they,
and
they can
medication?
they can only go for as far as we can only, because they present very late and very humongous
Tumors, my
size tumors
gosh.
of glioma, grade 4 and meningioma and everything. So when they present, they are very late. They are already lost something like neurological function or something like that. But we can only cut it out. And there are
Yeah.
very few places where we can actually diagnose it, actually go as far as that this tumor.
How about
and
like radiation therapy? We do that.
radiation?
here.
There is available radiation, but not as cheap and as available.
I see.
So because most of the people won't afford it, and they just die within 6 months or 2 years of glioma grade 4.
So
Yeah.
you've seen a lot of our
Not only this, Parkinson and so many.
Yeah.
So we are just resourceless people.
it's just up and coming.
Yeah.
So if all this the technology and everything you've seen, and you met Emma, who can tell you all about the nervous system from minute to minute, if you could take one thing back to Pakistan and make life and surgery and medicine better, what's the most incredible thing that you've seen so far?
Oh, this is a very difficult question. I want to take everything
That's a good answer.
Because-
that sounds expensive.
because we want to take everything, and then it's gonna take us a while to go to such. So the first thing that I would want to take back is the that you guys train me, and then I'll go back and try to do something about it.
No, I think that's going to happen. But I mean, from a technology point of view, like I think you were kind of
So
amazed.
I have seen navigations. So we don't use navigations.
and
And
even
also
in the brain.
even in the brain, when we are putting deep brain stimulators like the DBS, we are using the
X-rays.
no
No.
the different kind of not that as
Not
advanced
stealth.
robots and as advanced neuro navigation optical system that you have.
Oh,
We don't have optical navigators.
Yeah.
We have the stereotactic navigators, the old ones.
the
So
Lexel
even-
frame and
Lexus
Okay.
Raven,
yeah,
so
which
we
is
are
like
still using that for DBS and very
Wow.
fine things for the brain itself.
so that is a technology that kind of went out of favor, I'd say, in about, I still used it once or twice when in my training, 20, 30 years ago, but where I would say 1995 was sort of the end of using these. It's an old protractor that fits over top of the skull and is screwed in, and then all 3 dimensions. are lined up to trajectory like GPS.
Exactly.
And then you can drill a hole in the brain, in the skull, and then pass a catheter through the brain according to the triangulation. And
just
it was
like in the movies.
Yeah, well, we actually had to set the protractors like a ruler with a stop on it, and it would mechanically measure all this stuff out. And it would take all morning just to get the trajectory lined up. Now we just put something on the surface of the skull, and you could see inside the brain on the MRI where it would go. So nobody's being treated for Parkinson's very well then.
The people are being treated, but whosoever can afford the implant. This is almost 30 million implant, 30 million Pakistani rupees implant.
Oh, okay. So it's getting
that's a kind of expensive.
Wow.
And most of the people, they don't afford it, and the poor people, the 80-90% of the population, they just die because of aspiration, because of the small neurological dysfunctions and small aids. We don't have even nursing facilities, anything. Like if you
you're like a warrior out there just trying to create new healthcare. So well, we're going to take a break in a second, but I just admire you for knowing what you know and then going back and trying to make the best of it. I mean, that is a hard situation. You know, all these tools exist, but you don't have it, but still you try to find ways to help people. It's just, that's an awesome trait. All right, we're going to take a break. Doctor is in. Call us if you want to, 505-243-3333, and we'll be back shortly. All right, we're back. The doctor's in, and we're just chatting with two up-and-coming folks that are the future of neurosciences, I think. So we're just finishing with a segment here with Dr. Shahzeb from Pakistan. And so I asked you what technology that you've seen here that you would bring back if you could. There's all these problems that are happening in your country without resources. You're trying to be a doctor and a surgeon. And you just told me that the only way these patients get follow-up with you is you have to give them your actual cell phone number, and the doctors, the primary care doctors. So do you have patients calling you on the weekends and holidays? And
all the time. They don't let us sleep even. So we just put it on silent and sleep a little bit, and then
and
then get up and then start responding and all those things.
wow. So why did you go into it? Like, it seems like you don't have all the tools to do the job. Many years of study. What makes you passionate about this? Why would you put yourself through it?
So there are two things about it. When I was in med school, I already told that I was looking at neuroanatomy and neurophysiology, and this was very fascinating for me, because even if you are giving somebody a drug, it always have to involve neuropharma as well. You are sometimes addressing sympathetic, parasympathetic, something like that. So you give a drug, it always most of the time involves the brain.
So you always wanted to know the mechanisms,
because
by
it's
which
the most
drug-
important thing that is making us alive. So
you're,
that is one thing.
I know you published a number of papers on Parkinson's disease. Why does giving a pill in Parkinson's disease help? And you obviously studied it, right?
Why then?
Well, dopamine, like, why does it work?
So basically the basal ganglia that has some dysfunction. So substantia nigra, there's a part of midbrain. It just it just degenerates and doesn't make enough dopamine. So we start initially, people like the scientists, they started giving dopamine to the patient. So
and just so the audience is clear, so you have Parkinson's, you become kind of rigid, and the circuitry that controls the fluidity of your movements, and you have this sort of what do they call that? The very close step, unable to really walk well. And then obviously there's some dimension. So this area that needs dopamine you were talking about, that is degenerating. And then so we can give the pill.
So they initially started giving dopamine that would be converted in the periphery and won't reach the brain. Then they started giving a formulation that would reach only the brain.
So then they would walk better and they could get their.
They could better, but they come up with some side effects of it as well, because the dopamine it doesn't only necessarily work on the same place where it is but we are requiring it to.
And
it always it starts working on the other places as well.
Right.
So then they came up with the idea of DBS, deep brain stimulation.
So deep brain stimulators. We as neurosurgeons are taught to put this catheter down into that same area of the brain.
Yes, sir.
So rather than a pill, what does the catheter do?
So it just a very, very small amount of action potential and current it creates at the specific targeted areas where we want it to work, and then it just weans off the rigidity and motor dysfunction and all those things.
So the first time I saw a patient, they're awake for the surgery, right?
Yes, sir. Awake.
And then you put the catheter down with a computer, and then do you remember the first time you saw it when you turned the electricity on?
And we asked the patient to perform his repetitive movements like
squeezing
this,
the hand,
squeezing the hand and touching,
lifting a drink or something.
Yes, sir. So it was just initially the patient was very, very, very upset about the unwanted movements. When all of a sudden it came to the control, and he started picking up the things and started.
So normally they have terrible shaking, and all of a sudden it
was really magical,
like a light
and
switch,
dramatic. Yes, sir.
And so you looked at that and you said, I want to be the guy that fixes these people.
Yes, sir. Of course. Why not?
I love it. All right. Well, we're going to switch back to Emma. So you got what, 6-7 months, get your applications in. If you could go anywhere you want, and the admission officers were talking right now about your PhD in neurosciences, where would you go?
Ooh, I'm afraid to answer that, because what if they listen to this?
It's possible. If they're at UNM and they really want an experienced person.
It's a little bit complicated because I'm applying to 8 really fantastic programs, but applying for a PhD in neurosciences is not just like, oh, I want to go to grad school. I want to go here. I'm going to apply here and hope I get in, which is kind of more or less what it's like for med school.
Yeah.
It's all very nerve-wracking and very stressful. But for a PhD in neurosciences, you get admitted by a singular faculty member. So you have to signal who you want to work with. And so you have to, one, find university that has a program that you're interested in, neurosciences in general. They have to have faculty. Number 2, they have to have faculty doing the research you're interested.
Okay.
And then 3, you have to hope and pray that the person who is doing something that most aligns with your interests happens to be accepting grad students.
Okay.
So for the 8 programs I'm applying to, they're all varying in terms of the research topics and focus, but there's wonderful research going on everywhere. But I'm really keeping my fingers crossed for UC San Diego and Yale and Dartmouth and UNM, because UNM is my alma mater. And that's where I developed this interest in neuroscience. And so it would be wonderful to go back there. But if I'm
there
able
a
to spread my wings,
specific
it'd be great.
subtopic or a professor out there that's doing research that you want to focus on? Is there?
I would be a little bit nervous to name names because I'm so deep
but in other words,
these applications.
is there like a topic like the cerebellum, like Dr. Shezeb was talking about?
I'm really interested in stroke rehab,
Cool.
assessment and rehabilitation.
Neuroplasticity.
Yeah, neuroplasticity. One of my favorite things about the brain are
Is
mirror
that
neurons.
it can recover.
And it can recover, yeah. And it's really beautiful. But other areas are interventional behavioral therapies for adolescents with disruptive behavior disorders, as well as addiction treatments as well.
Do you know that Dr. Shezeb and I can put a catheter into an area of the hypothalamus and turn it on and stop some obsessive behaviors? That's been done.
Well, just come to my fully funded lab in the future, and we can have some great stuff going on.
If what comes out of this whole discussion is that we help your career and you cure some uncurable neurologic disease, I will have been very successful.
But yeah, cognitive neuropsychology, I think, is the best way to describe my special areas of interest. It'll be refined in the next 5 to 8 years, though.
Well, I'm sure AI is going to help with mapping out the circuitry.
Please don't remind me.
Well, no, but you have to harness that. The future is bright. It's just different than you expected. I went to this meeting recently about one of the spine robots we use, and it's going to collect all the data on all my cases, and then it's going to predict how well a next patient might. So I have to plug into this robot software what their BMI, how large they are, what their heart history is, all that stuff, and then it gives me a predictive model that tells me how well they would do and what to do, like what kind of surgery. And so there's going to come a point at which my judgment is good, but the computer's probably going to take over or augment a lot of that. I must make a plug, because part of becoming a neurosurgeon in America anyway is that they take you to a special course about your first or second year, and it's at Woods Hole, which is in a biology and oceanographics mecca of the world. Woods Hole is in Massachusetts, and we got to dissect I think it was a massive neuron from a whale or something.
Wow.
And you can fire it, and you can put action potentials across it, and it's just so I think that was Yale, but I'm not entirely sure who was associated with. But if you have a chance to do something, study the intrinsic ability of the brain to do these things, even if it's in a whale, it'd be great.
Cadaver labs are always where so much learning happens.
I love it. All right, Dr. Shezeb from Pakistan, any final words? Are you excited for your next challenge?
So I the way you were talking about the brain-computer interface and everything, I just want to become advanced functional neurosurgeon.
All right, wonderful.
That's my target.
And Emma, any last thoughts? Are we going to see you in the future back here when you've cured all these diseases?
I think all 3 of us will be back here talking about all of the new and advanced neurosurgeries we're working on.
I love it. All right, the doctor is in. Thank you so much for listening. We'll be back in 2 weeks, and we always appreciate your questions if you have them. And thanks to our 2 guests.
Thank you so much
for having us.
Thank you so much,
sir, for having us.
All right.
Thank you.